the next topic, which is the Frank Starling to Guyton Hall is our modern theories about how the body handles infusion fluids. Thank you.
Thank you very much. First, I must say how happy I am to be here today for the 7th edition, Manu. It's the 7th time that we meet for this IFAD, and this year in Amsterdam. It's always a big pleasure and a very nice and very friendly meeting. So to speak about physiology, and I first disclose that I collaborate with the following companies, with Pulsion Medical Systems and with Cheetah. What are we in fact speaking about? Why do we give fluid to our patients, basically? Let's go back to the very basic physiology. And to this, it's a way to represent the cardiovascular circuit. And I think it's a very nice way because it emphasizes the role of the venous tank, the large part of the venous tank in the cardiovascular physiology. We must understand the venous tank as really a reservoir when we can have some reserve in case of problems and especially in case of acute circulatory failure. When we give fluid to our patients, obviously, it is because we want to increase the cardiac preload in order to increase cardiac output. That's very easy to understand. But what's also clear on this drawing is that cardiac output equals venous return. The heart can only eject what it receives from the venous side. And so, in fact, with fluids, we want to improve venous return. What's also obvious is that the venous return is determined by the gradient between the mean systemic pressure and the right arterial pressure. So, in fact, it means that with fluids, we want to increase the mean systemic pressure in order to improve cardiac output. This is basically physiologically what we expect from fluid administration. Nevertheless, what is the relationship between this right arterial pressure and venous return? It is, as you know, the physiology of venous return as it's been described by Arthur Guyton. The relationship is this one, the venous return curve. So if we give fluid, we increase the mean systemic pressure, and we expect that venous return will improve in consequence. Nevertheless, and it's the big problem of fluid administration, you know that. The big problem is that this fluid administration leads to a significant increase in cardiac output in only half of the cases. Let's be reasonable. In fact, at the very early phase of sepsis, or in case of obvious fluid losses, all the patients respond to fluid administration. But after this initial phase, only one patient over 2 will respond to fluid administration by a significant increase in cardiac output. It was not that obvious years ago, but it became more and more obvious, and especially in 2002, in this review of the literature, Jean-Louis Teboul and Frédéric Michard showed that looking at all the literature, it became obvious that all patients do not respond to fluid administration. The explanation again stands in the basic physiology and in the relationship between cardiac output and cardiac preload. It's been described years ago now by Starling and by Frank. In fact, it's been described by Starling on the very basic experiments of Otto Frank. And they showed, in fact, both together that if you increase cardiac preload, stroke volume does not increase in a linear way. We are more used today to look at this relationship in the other direction. And it explains why, if we put on the same graph the venous return curve and the Frank Starling curve, we easily understand that in case of fluid responsiveness, when we increase the mean systemic pressure with fluids, it results in a significant increase in venous return and thus in cardiac output, because both are equal, because the patient's heart is working on this steep part of the Frank Starling relationship. By contrast, in case of preload unresponsiveness, because of the flat slope of the Frank Starling relationship, the same increase in mean systemic pressure with the same increase in mean systemic pressure does not increase cardiac output significantly. Fluid unresponsiveness and fluid responsiveness, all this is explained by basic physiology. That's theory, but is it really what happens in our patients? Is it really the explanation in our patients? In fact, likely yes, and we have today some experiments in human beings telling us that it really occurs. Why? Because today we have some ways to explore the venous return physiology at the bedside. This is what we did 3 years ago in this study. We published with patients in whom we explored the mean systemic pressure with a method that I won't have time to detail, which uses heart-lung interactions. And using the ventilator settings, we can estimate the venous return curve at the bedside. And we examined two types of patients, fluid responsive or preload responsive and preload unresponsive patients. And we observed that in both types of patients, fluid administration led to a significant increase in the mean systemic pressure. The venous return curve was transferred to the right side. And this increase in mean systemic pressure was the same in preload responders and preload non-responders. But in fact, what explains the fact that some patients responded and some others did not respond to fluid administration? In preload responsive patients, again because of the slope of the Frank Starling curve, the increase in the mean systemic pressure was accompanied by an increase in the right atrial pressure of a lower extent. It means that the pressure gradient between the mean systemic pressure and the right atrial pressure significantly increased, leading to a significant increase in cardiac output. The difference in non-responders was that the same increase in mean systemic pressure, because of that slope of the Frank Starling relationship, led to an increase in the right atrial pressure that had the same amplitude, explaining why the pressure gradient of venous return between the right atrial pressure and the mean systemic pressure didn't change. This explained why cardiac output didn't change. All this is explained by the properties of the venous return. So response, no response, all this explained by physiology, that's confirmed in our patients. What are the clinical implications? I think it's not only physiology. It can have some real implications at the bedside. Three implications. The first is the value of CVP. I mean that it's really something that I think is important today. We must measure CVP at the bedside. Even if it's not for predicting fluid responsiveness, we must measure it because it's a very important physiologic variable. For instance, let's imagine a patient with septic shock pneumonia. First day, the patient has received saline and received norepinephrine. And I give one more fluid bolus to my patient, but cardiac output does not increase. There are two possibilities. Perhaps the patient is fluid non-responsive, but perhaps also the dose is not enough. It did not increase cardiac output enough. How is it possible to know whether my fluid administration really actually increased cardiac preload significantly? Likely by looking at the central venous pressure, because as we have seen before, typically patients who do not respond to fluid administration have a significant increase in the right atrial pressure that explains why cardiac output doesn't change. By contrast, if CVP does not increase with fluid administration, likely it means that actually there was a capillary leak or there was a very large fluid tank such that the fluid I administered did not increase cardiac preload significantly. It means that typically in fluid non-responders, CVP must increase. If not, it suggests that preload did not increase enough. The second consequence is likely, of course, for the prediction of fluid responsiveness, because if we know all the risks of fluid administration, it's logical that we want to predict fluid responsiveness at the bedside. In this patient, especially in case of ARDS with a low PF ratio, with a high PEEP and such a chest X-ray, should I give fluid or not? I won't enter into details in this session because it will be the purpose of my next lecture. But just to tell you that, in fact, all the tests we have to assess preload responsiveness are made for assessing the Frank Starling curve at the bedside. In fact, this is what we do with all these tests. Again, the algorithm is very simple. In case of obvious fluid losses at the very early phase of sepsis or in case of hemorrhage, that's clear we should not test fluid responsiveness, but in the other cases where actually not all patients respond to fluid administration, we need these tests. I will show you 4 tests this afternoon in my next lecture. But all these tests, again, test the Frank Starling curve at the bedside. That's the principle. With the fluid challenge, the principle is that you give fluid, and if cardiac output increases, you give fluid again and again and again until the last bolus that does not increase cardiac output anymore, and you stop fluid administration. You test the Frank Starling curve at the bedside. But the basic problem with the fluid challenge is that it inherently leads to fluid overload, because it's obvious that if hypertension occurs again, and if you still use the fluid challenge to test fluid responsiveness, at the end of the day, your patients will have received a non-negligible amount of fluid that obviously contributes to fluid overload. And that's why some other ways to test fluid responsiveness without giving a drop of fluid have been developed. PPV and SVV, in fact, at the bedside also test the Frank Starling curve, challenge the Frank Starling curve. The principle is very easy to understand. In fact, during mechanical ventilation, X insufflation decreases cardiac preload. So it means that there are cyclic changes in cardiac preload with mechanical ventilation. If it changes stroke volume and pulse pressure significantly, likely the patient is fluid responsive. It's the case also with this end expiratory occlusion test that is also based on heart-lung interactions, because if we stop mechanical ventilation at end expiration for a few seconds, as I will show you, in fact we induce a short, like a preload bolus that will cross the pulmonary circulation and increase cardiac preload and output in case of fluid responsiveness. And it's obvious that we do the same with a passive leg raising test where we challenge the Frank Starling curve at the bedside. All this is related to physiology. Finally, an important consequence of this physiology is likely for revisiting the effects of norepinephrine. Because basically, if we give norepinephrine, it is to increase the arterial pressure, to use the arterial vasoconstrictive effects of the drug. But norepinephrine also increases cardiac preload. It's been demonstrated by some studies today. For instance, here we showed that along with volume expansion, giving norepinephrine significantly increases the CVP or the LV and diastolic area. And all this is related, and it's my point now, to the venous effects of norepinephrine, because we must bear in mind that there are some alpha receptors, alpha adrenergic receptors on the venous side also. And when we give norepinephrine, it fixes also these receptors on the venous reservoir. And it induces a significant vasoconstriction that reduces the size of the unstressed blood volume and increases the size of the stressed blood volume, leading to an increase in mean systemic pressure and also to an increase, a small increase in the resistance to venous return. And in humans, it's been demonstrated by at least 3 studies today. In this first one we published, we showed that using the same technique, the same method I told you before, that we increase the mean systemic pressure when we increase the dose of norepinephrine. And the resistance increases, but to a lesser extent. It means that if I give norepinephrine to my patient, I also increase mean systemic pressure, just as with fluids. This is an additive effect. But that's not all. Because if I give norepinephrine, I will also reduce the size of the venous tank in which the next fluid administration will dilute. It means that if I give fluid, the next fluid administration may be more efficient. This is what we showed in this study that's not published. You see, we performed a passive leg raising at a lower dose of norepinephrine. And we showed that at this lower dose, the effect on mean systemic pressure was less. It means that the increase in mean systemic pressure provoked by passive leg raising, just like with fluids, led to a lesser effect on mean systemic pressure, suggesting that if you give fluid to this patient, you increase the mean systemic pressure, but if you give norepinephrine or if you increase the dose of norepinephrine, the next fluid administration will have a greater effect on cardiac preload and likely on cardiac output, suggesting a synergic effect of norepinephrine with fluid administration. Thank you very much.